Hello, everyone, and welcome to tonight's webinar entitled Women's Postpartum Pelvic Health, hosted by Zion Physical Therapy. My name is Dr. Staci Levine, and I am so excited to be here tonight to shed a little bit more light on what pelvic health PT is and how we as a company and as a profession can really help the postpartum population. A little bit about me first. I am a doctor of physical therapy. I'm the COO and pelvic health program director of Zion Physical Therapy. I graduated from Columbia University's DPT program in 2008. I became a pelvic health practitioner certified through the Herman & Wallis Institute in 2017, and also am an orthopedic certified specialist through the American Physical Therapy Association, and truly have a passion treating patients with orthopedic injuries and pelvic floor dysfunction. A little bit about us, Zion Physical Therapy. We have 4 office locations, the first being the Upper East Side of Manhattan on 87th and 3rd, right across from Whole Foods. The Upper West Side office is 72nd and Riverside. We have a Jersey City location in the Newport Center in Metro USA, right off the Newport Path station, and in Westport, Connecticut. If you want to learn a little bit more about our locations, where our practices are, or about our PTs, you can go to www.zionpt.com. And I just want to mention, this webinar is definitely based and geared more towards the postpartum population, but our PTs treat not only the prenatal and postpartum patients, but also men and women with musculoskeletal symptoms associated with urinary, sexual, bowel dysfunction, and pelvic pain. So all of our PTs treat both orthopedic diagnoses in addition to pelvic floor dysfunction diagnoses. And we also treat the HEDS, HSD, Ehlers-Danlos patient population as well. So again, log on to www.zionpt.com for more information about our PTs and the patient populations that we treat. But super excited to get this going and talk more about the postpartum pelvic health population. So here we go. Overview, what we're going to talk about today. Pelvic floor anatomy and function, the changes that occur during pregnancy, prenatal diagnoses that pelvic health PTs can treat, what happens during a vaginal delivery versus a C-section, and things you should know to ask your provider, but then also to relay this information to your pelvic floor PT when you see them. Normal versus abnormal postpartum symptoms, postpartum diagnoses that pelvic health PT can help with, what to expect during a pelvic floor evaluation, and then what are our PT treatment approaches, what to expect during your treatment sessions and follow-ups. And then this is my favorite question, to Kegel or not to Kegel. This will hopefully be answered at the end of the webinar after you have a little bit more information and education regarding pelvic health PT and the pelvic floor. And then we'll do a Q&A at the end. Okay, so starting with pelvic floor anatomy. The pelvic floor itself is a muscle group, and it sits in the bony pelvis that connects to the lower extremities and the spine. So I have a female pelvic model right here. Everything you see in white is bone. You have your spine, your sacrum, and your tailbone in the back. You have your pubic symphysis in the front. You have your ischial tuberosities on the bottom. And then everything you see in red is pelvic floor. There are 3 layers to the pelvic floor. The first one is superficial. You have your external anal sphincter, your ischiocavernosus, your bulbospongiosus, and your superficial transverse perineal muscle. You have your urogenital diaphragm, which is layer 2, located a little bit more internally, and these muscles are circumferential around the urethra. And then layer 3, otherwise known as the levator ani, is your pelvic diaphragm, which consists of your pubococcygeus, iliococcygeus, and coccygeus. And these muscles are located much deeper in the pelvis. The pelvic diaphragm boundaries are the pubic bone in the front, like I was saying, the ischiopubic ramus and ilium on the sides, and the sacrum, coccyx, and piriformis in the back. So the functions of the pelvic floor are many. It's a group of muscles that's housed within the bony pelvis that forms a sling and functions to what we provide the 5 S's. So the first one is support. You have your bladder, your rectum, your uterus, your intestines all sit on top in this pelvic bowl on top of the pelvic floor. So the first function is support. It needs to be able to have good contractility and not too much laxity in order to help support all of the organs on top of it. They are sphincteric in nature, meaning that they control the opening to the bladder, the urethra, and rectum. They contract to prevent leakage, and they also relax to allow urination and defecation. They provide stability. It's an integral part of the core. It works with the abdominal muscles, the hip muscles, and the back muscles, specifically the diaphragm, the multifidi, the pelvic floor, all work together to provide stability to the system. So you really need a stable core in order for all of your extremities to function as efficiently as they should. And if you're lacking this stability, that can lead to a lot of pain and inefficient movement patterns. It provides sexual function. You need the flexibility in the pelvic floor to allow for penetration, but you also need strength to provide the ability to have an orgasm. And it acts as a sump pump. It acts as a blood lymph pump for the pelvis. So dysfunction in this area can lead to swelling or congestion in the pelvis. And that's something that we can help with as well. So what are the changes that occur during pregnancy? What could be happening that would provide for dysfunction following a vaginal delivery or C-section? You have a huge hormonal shift. Your follicle stimulating hormone, your luteinizing hormone, your estrogen, your progesterone, your relaxin, everything is much, much different during pregnancy. And you also have a major shift once you've had the baby that occurs afterwards. So specifically relaxin is meant to help the pelvis kind of relax a little bit in order for your sacroiliac joint and your pubic symphysis to allow for your growing belly and allow relaxation in some of these ligaments and muscles so that you can have a vaginal delivery and have the baby pass through the vaginal canal. But that can also wreak a little bit of havoc on the body if you're not as stable as you once were. Your abdominal muscles stretch and elongate to allow for your growing belly and your growing fetus. Your center of gravity shifts. We call this like the pregnancy posture, where you have this little bit of what we call an anterior pelvic tilt, where you are essentially allowing your abdominal muscles to elongate in the front, but that can also cause your center of gravity to shift forward and provides a lot more challenge for your back to kind of maintain that upright posture. You have increased pressure on your pelvic floor muscles for obvious reasons. The baby is sitting right on it. Your rib cage expands, again, to allow for the growing belly, but this can also wreak havoc a little bit on your diaphragm and your rib cage and your thoracic spine. The ligaments soften to allow for the growing belly, as we discussed with the increase in relaxin, and you have increased fluid levels. So before we get into the postpartum, I just want to touch on some prenatal diagnoses that pelvic health PTs can treat. And we see this very often. Pubic symphysis pain is that joint in the front of the pelvis that, again, it is meant to be a very stable joint, but with the changes that are happening, sometimes it does move and does stretch a little bit, and that can be very painful. So we as PTs really can help to make sure that all the muscles around that joint are flexible, but are also strong, and we can help provide some taping techniques or stability belts that can help provide relief to that joint. Sciatica is probably the number one thing that we see. Pain kind of that originates in the lower back and kind of goes down into the butt and into the leg. Again, providing stability, core activation, posture education, all of that stuff, we can really help to minimize these symptoms while you are pregnant and as you go from your first trimester to your second trimester to your third trimester. Pain in the hips is pretty common. Pelvic pain, urinary incontinence is a big one, making sure that your pelvic floor is as strong as it needs to be and that you're utilizing it with the movements that are causing the incontinence. Lower back pain for obvious reasons. SI joint pain, again, the joint between your sacrum and your ilium, because of the relaxin and all of the hormones that are coursing through your system and allowing for the growing belly. This can create a little bit of pain in the sides of your lower back. Upper back pain, again, your upper back muscles are working hard to keep you upright with the growing belly. And also trouble transitioning from sit to stand, lying down to sitting up, rolling in bed. All of these things can be a little bit more painful now that you have, this weight in front of you. Shortness of breath is also a common one due to rib cage restrictions or the inability of the diaphragm to descend all the way. And we really want everybody to know that a pelvic PT can help you prepare for a vaginal or C-section delivery by practicing optimal laboring positions, teaching the patient how to do perineal massage, teaching your partner how to do perineal massage to help relax the pelvic floor and the perineal body to be able to stretch as much as it can during a vaginal delivery. And also education regarding strategies for pain relief, improved recovery and function after a vaginal delivery or a C-section, and caring for your baby after delivery. Another thing that we really like to prepare you for are some of the things to expect immediately postpartum, and also things that we'll get into a bit as far as what are normal symptoms kind of in that immediate postpartum to 3-month postpartum time period, what red flags to look for, what things that you need to contact your provider about immediately postpartum, and then also things that, like, you know, you feel okay in that immediate postpartum period, but then 3 months down the line, you're still dealing with some issues. So we provide as much education as we can regarding those things, and we definitely follow up with you after you've had the baby and can be a source of education and knowledge and help after delivery. Okay, so just to touch on a little bit of the obvious differences between a vaginal delivery versus a C-section, but when you are with a pelvic health PT after you've delivered a baby, whether it's a vaginal delivery or a C-section, we're going to ask a ton of questions about your vaginal delivery or C-section. So it's really good to know kind of these things up front before you have either, so that you can relay as many specific details as possible so we can provide the best care knowing what you've been through. So for a vaginal delivery, you know, the optimal positions for the pelvic floor to be able to relax and stretch and elongate are typically quadruped, which is kind of on your hands and knees. A squatting position, whether you are holding on to like the back of the hospital bed or a pool if you're having a home delivery, the bed, or if you're literally squatting on the floor, that is the relaxation position of the pelvic floor, and that will help to elongate some of these muscles. Also in standing and side lying versus lying on your back kind of in the lithotomy position. Your sacrum and your tailbone are sometimes immobilized in that position, and that can sometimes lead to a little bit more increased tearing or pressure on the pelvic floor because you're not able to expand posteriorly. So again, this is all without an epidural. So if you don't have an epidural and you have full function of your legs, quadruped, squatting, standing, side lying are great positions for the pelvic floor to be able to expand appropriately as it stretches up to about 3 times its length. If you do have an epidural, by all means, lying on your back is okay. Side lying might be a little bit better just for optimal pelvic floor length. You deliver the baby and the placenta. So after you deliver the baby, there's also the placenta to deliver. A lot of people aren't super aware that that is happening as well. If the baby is not descending down the birth canal as quickly, or the baby's in distress, or the mom's in distress, your OBGYN, your OB or your midwife might use forceps or vacuum if necessary. This can sometimes lead to a little bit more tearing. And also if the baby isn't descending as rapidly or is in distress, they might do an episiotomy, which is essentially a controlled incision in the bottom part of the vaginal canal. Usually they do it medial laterally, so they don't go straight down into the anal sphincter. They'll do that to allow more space for the baby to come out of the birth canal. Tearing, you can have 4 different kinds of grades. Grade 1 is only a little bit posteriorly in the back of the vaginal canal. Grade 2 kind of goes halfway in between the back of the vaginal opening and the rectum. Grade 3 goes into the anal opening, but not through it. And then grade 4 goes all the way through. So you're really trying to avoid grade 3 and grade 4. Sometimes it's unavoidable, and that's okay. We deal with it afterwards. But sometimes that's when they would do an episiotomy. If they think that there's going to be a big tear, they'll do an episiotomy to control the tearing, and then they'll be able to stitch it back up. For a C-section, you may have a choice whether you have spinal anesthesia or general anesthesia. Typically, check with your OB and midwife on this, but typically spinal anesthesia is better for the baby versus putting you under completely. But it's good to know what you went through when we're doing the evaluation. Typically, they'll do an incision horizontally through the lower abdomen and uterus. They'll use a catheter, and you won't really have full bladder function until several hours after the C-section. There is scar healing time and limited lifting and driving. Typically, you'll have a visit at your OB 2 weeks postpartum just to make sure that everything is healing the way that it should, and 6 weeks postpartum where they'll clear you for exercise, sexual intercourse, PT, and sometimes scar mobilization. But again, everybody's a little bit different, and it's really, really important to keep your 2 week and your 6 week follow-up with your OB or midwife. Okay, so what are some normal pelvic floor changes and symptoms and things that we would expect less than 3 months after delivery? From a urinary function perspective, you might have minor urinary leakage with sneezing, coughing, laughing, or lifting, basically anything that causes an increase in intra-abdominal pressure or increased pressure on the pelvic floor. It has been through a lot, both in pregnancy and with a vaginal delivery. Even with a C-section, this might still happen. Urinary urgency, there's still a lot of swelling present in the lower abdomen, around the urethra, and the uterus is returning back into its normal position and size. So everything might just feel a little bit congested down there. Again, normal within the first couple weeks. Urinary hesitancy, again, you still might be swollen in the area of the urethra, so you might sit down and not be able to completely void right away. This should get better over time. Nocturia is getting up to go to the bathroom more than one time a night. Again, within the first 3 months of having a baby, you're up multiple times a night feeding that baby. So if you go to the bathroom a couple times, it's okay. But as the baby sleeps through the night, you should not be getting up multiple times a night to go to the bathroom. From a bowel perspective, constipation can sometimes be expected due to muscles being overstretched and unable to engage your core to push. Sometimes they'll give you a stool softener preemptively or after the delivery to assist with this. Not a bad idea, especially after vaginal delivery. That first bowel movement can be a little scary, but using a stool softener, drinking plenty of water, even using a little bit of prune juice, something to just help make that be not a scary or painful experience. But again, with the hormone shift, with the lack of activity, constipation can happen after a delivery, vaginal or C-section. Also with the pain meds can be very constipating. So make sure you're, again, drinking a lot of water and talking to your provider if you're having an issue. Minor fecal soilage and staining. Again, if you've had a vaginal delivery, the pelvic floor goes through so much and might just not have that contractility or normal function. You might have a little bit of fecal soilage and staining, and discomfort with bowel movements. Again, if you've had a vaginal delivery and there's stitches in the area, it's not going to be comfortable for a little while, but all of these things should get better. Sexual dysfunction after delivery, lack of desire to have intercourse. Most OBs don't recommend it until you're fully healed anyway, about 6 to 8 weeks or longer. They really want to make sure that that tissue has healed, especially if you've had a vaginal delivery. But even with a C-section, you can have discomfort with intercourse for the first 3 to 6 months, especially if you're breastfeeding. Your hormones are not yet back to normal. The vaginal wall may be dry and thin due to the plummet in estrogen. Give yourself a little grace. There's definitely things that can be done after you're cleared for sexual intercourse with pelvic PT and with working with your OB to make this better. And then discomfort because of scar tissue from the episiotomy or tear. There's a lot of nerve endings down there in the vaginal area and the perineal body. If you've had an episiotomy or a tear, there might be discomfort or lack of flexibility in the scar tissue that can become a little bit painful. So again, there are definitely things we can do to help that afterwards, after you've been cleared by your OB. So common dysfunctions that should be addressed by your healthcare provider after 3 months postpartum. A lot of the things that we just talked about. If you are continuing to experience these after about 12 weeks postpartum, don't be afraid to reach out to your provider to get help, because these are things that we can really help with quickly. And the sooner the intervention, sometimes the sooner you feel better. So urinary dysfunction, stress urinary incontinence, which is, again, that intra-abdominal pressure, the lifting, the coughing, the sneezing. Urinary urge incontinence, this is basically when you are walking down the hall to your apartment, you have to go to the bathroom, you put the key in the door, you're like, oh my God, I gotta go, and you lose control. We can help with that. Urinary urgency frequency, going too often, stopping and starting, not being able to empty completely, and again, nocturia, urinating too frequently at night. Sexual dysfunction, If pain with intercourse is still happening, which is called dyspareunia after that 12-week mark, or you're having pain with tampon insertion or gynecological exams, or you feel like you literally cannot get into the vaginal canal, which is called vaginismus, or you have pain with arousal or orgasm, all of these things can be pelvic floor related, and a pelvic health PT can assess those muscles and see and create a treatment program as to what we can do to help these muscles kind of relax and expand. Bowel dysfunction, one can experience fecal incontinence, constipation, incomplete emptying, significant hemorrhoids, pain with bowel movements. Again, speak to your OB, midwife, gastroenterologist. Some of these things can absolutely be pelvic floor related. Pain, lower back pain, hip pain, tailbone pain, perineal pain, pubic symphysis pain, SI joint pain, abdominal pain. Your body goes through so much during a vaginal delivery and a C-section that there can be a lot of muscle compensation and muscle inactivation as a result of the swelling and surgery and tissue trauma, that we really need to kind of put the pieces of the puzzle back together and help you activate everything as you should. Prolapse. There are different types and grades of prolapse. A cystocele is a bladder prolapse. A rectocele is a rectum, the posterior wall of the vaginal canal coming down too far into the vaginal canal. A urethrocoele is when the urethra prolapses a bit, and uterine prolapse is when the cervix kind of comes down into the vaginal canal. There are 4 grades of this. Grades 1 and 2, we can definitely help to minimize these symptoms related to it. Grade 3 and grade 4, we definitely would be working with your provider to figure out the best way to minimize those more severe prolapse. But you can have a feeling of dropping of your organs, pelvic heaviness, or even noticeable tissue bulging from the vaginal or rectal opening. Definitely want to get that checked out by your OB or midwife, and then talk to your pelvic health PT about what we can do to help support those tissues. Diastasis rectus abdominis. This is a big one. I feel like this is a hot topic. It's a separation of the linea alba and the rectus abdominis musculature. So I always describe the rectus abdominis musculature as your like 6-pack ab muscles. It's 2 muscle bellies that's connected by connective tissue in the middle, which is your linea alba. When you are pregnant, this is meant to expand and separate because you need to allow for your growing belly and your growing fetus. After you've given birth, this connective tissue and the 2 muscle bellies don't always just go right back and kind of live as they once were prior to pregnancy. You need to be able to transfer load and be able to stabilize your core muscles so that you have that support for your activities of daily living. And it can feel like you don't have full control of your abdomen. You might have a little bit of lower back pain, or you might feel like you still look like 4 months pregnant because you just can't get rid of that kind of bulging in the abdominal area. Your OB, your midwife, and definitely your pelvic health PT should be able to check if you have one. And then there are so many things that we can do in the office to help retrain those muscles to kind of approximate a little bit more. Breast pain, infection of the milk duct. It can also be a less severe blockage of the milk duct. Again, we'd be working with your OB and potentially a lactation consultant to help you with these issues. All our diagnoses of pelvic physical therapists can help treat. A lot of people just don't even take into account that there's help from a musculoskeletal perspective for a lot of these symptoms. Did you know in most European countries, postpartum women are automatically sent to a pelvic floor PT after their 6-week follow-up visit to assess their pelvic floor function and their core function and muscle length and strength after a vaginal or C-section delivery? This, I feel like, is one of our missions, is to spread awareness to the OB population, to the GYN population, to the midwife population, to literally everybody, that this is a beautiful, beautiful, beautiful experience, but can also be very traumatic during pregnancy, during delivery, and then postpartum from like so many different aspects. If you think about it, in most orthopedic surgeries, rotator cuff repair, ACL reconstruction, total knee replacement, you're immediately sent to an orthopedic PT for rehab. A C-section is a surgery, and episiotomy is an incision. Like this is very similar to a surgical experience and a traumatic experience for your body. So why aren't people automatically sent to a pelvic health PT to be at least assessed to make sure that everything is working correctly after you've been pregnant and delivered. So off my soapbox, very much in support of discussing whether pelvic PT is appropriate with your OB or midwife after you've had a baby or even before you've had a baby. So what to expect during your pelvic floor PT evaluation? We have so many patients who come in and they're just like, I don't know why I'm here. I really don't know what to expect. They're super nervous. And again, I definitely want to spread awareness of what to expect during these evaluations and follow-up treatments so that it becomes more commonplace and people aren't so anxious. All evaluations, especially here at Zion PT, we are one-on-one for 45 minutes. We don't have any treatment aides. We don't have any PTAs. No one. It's you and your PT in a private treatment room. You are always welcome to a chaperone or family member. Bring them in. The more the merrier. We really don't mind. If anything, it's another person to kind of help recap your full past medical history and then be able to help you with the treatment plan going forward. So what do? We take a full past medical history. We talk about your pregnancy history, your delivery history, and what's been happening since. We ask you your chief complaints, your functional limitations. What are you not able to do? What do you want to be able to do? Do you want to go back to Pilates? Do you want to run a marathon this fall? Do you just want to be able to take long walks with your baby? Do you want to be able to breastfeed and pump without your back killing you? We do a posture assessment. So again, a lot of pregnant people tend to still have this interpelvic tilt and kind of forward center of gravity after having a baby. And so we just want to make sure that you are kind of living in the correct posture, whether it's sitting, standing, walking, so that we're not perpetuating some of these faulty mechanics. We do abdominal wall assessment, scar assessment, diastasis rectus abdominis assessment. We do a pelvic floor exam, both externally and internally with consent via the vaginal and rectal canal to assess the ability to contract appropriately, relax appropriately, and also bulge. We test the power and the endurance of the musculature and look for myofascial restrictions present that could be leading to pain. We assess hip range of motion, flexibility, and strength, mainly because these muscles insert so closely into where the pelvic floor lies. And if appropriate, we can do a biofeedback assessment using either a vaginal or rectal sensor. A lot of times I don't do this on the first initial evaluation anyway. We are usually doing so much of what is above first, and then if we find it's appropriate, we'll do it the next session. And we'll get into a little bit more of what biofeedback is later. So how is pelvic floor dysfunction treated? Treatment's really based on the results of the thorough evaluation provided by your pelvic floor PT and how your muscles are functioning and what we find. Everything listed here are all kind of our tools in our toolbox. We may do everything with one person. We may do only a couple of things with one person. It really depends on what we find during the evaluation. Manual therapy can be targeted to release tight musculature and trigger points, both externally and internally. Whether it's by the vaginal canal, if it's more of a sexual dysfunction or urinary dysfunction, potentially the rectal canal, if it's an incomplete emptying or constipation or rectal pain dysfunction. Neuromuscular re-education, we are always looking to retrain the muscles to be able to contract appropriately, relax appropriately, and stretch or bulge appropriately. Your bicep needs to be able to do the same thing. It needs to be able to contract, it needs to be able to relax, and it needs to be able to stretch a little bit. So the pelvic floor is just another muscle group that needs to be able to function correctly. We might do some stretching, some strengthening of the pelvic floor, of your core, of your low back, of your hips. We can do biofeedback. I'm going to get into what biofeedback, dilator therapy, pelvic wand, and anorectal balloon retraining are in a minute. We do posture education. We do, activity modification when caring for yourself and your new baby. Again, I keep saying it, your body goes through so much during pregnancy and delivery, and now you're responsible for this human that you have to bathe, that you have to feed, that you have to lift, that you have to carry. And your body needs to be able to withstand those forces and new activities. Sometimes we'll use some taping techniques to enhance mobility and stability. And we also collaborate with your other healthcare providers. Whether it's a GI that referred you, a nutritionist, acupuncturist, OBGYN, urologist, or pain management, and then home exercise program. There's a whole slide for this because it is so important to take what we teach you and utilize it at home. So what are some of these PT treatment approaches we just mentioned? Excuse me. Manual therapy. We'll do abdominal visceral mobilization. All of the organs kind of move out of the way for that growing uterus. They don't always just kind of go right back into place. We can make sure that everything's gliding and moving on each other. We do scar tissue work, whether it's from an episiotomy, tearing, or C-section incision, colonic massage if there's any GI dysfunction, diaphragm release. Again, the diaphragm can get very tight from not being able to contract and relax appropriately from having this big belly. We do external myofascial under trigger point release to the pelvic floor, to the lumbar spine, to the hip musculature, basically anything that we find needs a little bit of release. We also can do internal myofascial under trigger point release to both the superficial and deep musculature we were talking about before, again, appropriately through the via the vaginal canal and a rectal canal with patient consent and clearance from your doctor. Manual stretching to the hips, and also joint mobilization when appropriate to the hips, lumbar spine, coccyx, sacrum, or SI joint. Some of the other treatment approaches that we'll use, for example, dilator therapy or pelvic wand, for patients who have a lot of trigger points in their pelvic floor, areas of tissue tension, pain with intercourse, a vaginismus diagnosis. A lot of times they can benefit from a dilator or a pelvic wand use at home. If you're in PT once a week, twice a week, once every other week, that's great. What we do in the office is really meant to help educate and teach the tissues how to be. And then these are two great tools to help with follow-up at home. So dilators, which is this, the picture to the right, these are Syracuse Medical dilators. We are not affiliated with either of these two products. They can be used as a way to help stretch the vaginal and or rectal opening circumferentially. So if somebody is having dyspareunia, pain with intercourse, or vaginismus, they're not even able to insert a tampon or anything. These are great to help release tension in the tissue on your own. And what we have you do is we'll send you the link, we'll have you purchase the product, we'll have you bring it in, and then we'll teach you how to use it effectively at home. Same for the pelvic wand, used at home to perform internal soft tissue releases by the vaginal or rectal canal. This point is used for the vaginal canal. This point is used for the rectum. And again, we teach you how to use it. It looks a little scary at first, but a lot of times it's so crucial to kind of get that tissue tension release multiple times throughout the week that if you can't come in and have your therapist do it over and over again, this is a great way to kind of reinforce it at home. Biofeedback and NMES. Biofeedback is this machine to the right, this top picture. We use an MR15 unit to basically assign objective measurements to pelvic floor tone. So if you are in an assessment and your pelvic floor PT is like, okay, everything's really tight, everything's really tender, there's a lot of tension here, this assigns a number to that. So it helps kind of just bring objective feedback for the patient to be able to see what the therapist is talking about. It assesses both resting activity level of the pelvic floor in addition to strength of both the fast and slow twitch muscle fibers in relation to power and endurance. So you would need power for something like coughing, sneezing, lapping. You need that short, strong contraction to counteract that pressure. You need endurance or slow foot twitch muscles in order to be able to walk from one end of the hallway to your apartment building, hold that pelvic floor contraction as you feel like you need to urinate so you don't leak. It can be used with exercise to increase tone when you have a hypotonic pelvic floor or a weak pelvic floor, such as in incontinence or prolapse, potentially, and down training strategies to decrease tone if there's hypertonicity present. So in a situation of pelvic pain or constipation, we can help with some breathing strategies, some relaxation strategies to get those muscles to let go. NMES is neuromuscular electrical stimulation. It's this middle picture right here. It's a pathway STM10 vaginal and rectal intercavity unit, and this is used more to stimulate muscle contraction to aid in proper facilitation of the pelvic floor. Both of these units are used with either an internal vaginal sensor or an internal rectal sensor. Again, it depends on where the area of dysfunction is and what the patient can tolerate. The NMES is more so used with patients who are really having trouble and difficulty finding their pelvic floor. they're using their abs, they're using their glutes, they're holding their breath, but they cannot get that pelvic floor contraction. This can be used to help find those muscles. So what it does is it creates like a little bit of an impulse of the pelvic floor, and then we're able to have you kind of contract with that and recruit more muscles as we're using this unit. It's used with active and rest cycles geared to improve strength. But it also can be used to improve urinary urgency and hypersensitivity. If somebody is having almost too much input to the system, there's a setting on here that we can help to utilize to decrease urinary urgency and hypersensitivity with bowel movements. We can also recommend home units for these two treatment approaches. We have the units in the office and we have the patient purchase the sensor, but there are also home units that one can use if they find it really helpful to be able to see the feedback on a more regular basis if you don't want to use it just in physical therapy. Anorectal balloon retraining, I think we use the least often, but it can be a very helpful tool for the patients who are needing to retrain proper sensation and urge to defecate. The use is of a small balloon that's inserted into the rectum, and it's attached to a tube and a syringe, and we increase the amount of water or air in it while it's inside to help re-educate proper sensation and urge to defecate. And this, when appropriate, can be very, very, very effective, and it doesn't take a lot of treatment time with this. So this is something that we can use as well, and that we can also teach you how to use at home if you want more practice. Homework. Home exercise program is so important. Again, if you're only in PT for 1 to 2 sessions a week, if that, you really need to be following up with some of these exercises and treatment strategies at home. Your PT will prescribe appropriate exercises and strategies based on the impairments, functional limitations, and goals that you discussed in the evaluation. There are home units available for biofeedback and NMES if appropriate. In addition to the dilator therapy, the wand, there are tools that we can use to really help enforce home exercise program. And then we'll schedule follow-up visits as needed. The frequency can be anywhere from 1 time a month to 2 to 3 times a week, depending on the plan of care, your MD recommendations, your insurance. We take all of this into consideration and try to really devise the best plan of care for you. And the goal is to achieve all of our patients' goals that are set during the initial evaluation and really have you feel like you are able to conquer the world after having a new baby. So here we go. Here's my favorite question: to Kegel or not to Kegel? What is a Kegel? A Kegel, or what we call uptraining, strengthening, is a pelvic floor contraction geared to improve strength and endurance. When should you be doing Kegels? When you have a confirmed weakness and or laxity in the pelvic floor muscles causing symptoms. When should you not be doing Kegels? When should you be doing reverse Kegels? Reverse Kegels, or down training as we call it, is exaggerated relaxation geared to decrease tone, pain, or overactivity of the pelvic floor. When should you be doing reverse Kegels? When you have a confirmed hypertonicity and or tightness of the pelvic floor that is believed to be causing symptoms. But how do you know what's right for you? You just gave birth, you're in pain, you have no idea what's going on with your pelvic floor. Go get evaluated by your OB, your midwife, and see if they will provide a referral to a pelvic health PT. In the state of New York, we do have direct access as PTs to be able to see patients without a prescription. However, in the postpartum population, I always like to have medical clearance by your OB or your midwife in the form of a prescription or a referral, just to make sure that there are no organic reasons as to why you're having the dysfunction that you're having. So we just like to make sure that you're medically cleared from a tissue healing perspective to make sure that we are not overstepping our boundaries as PTs and really have the ability to coordinate our plan of care with your other healthcare provider. So that is it as far as the webinar goes. My contact information is below. The office line is for all 4 offices. So if you call this number wanting to go to the Upper West Side office, still call this number. It goes for all 4 offices. My work email is staci@zionpt.com. And again, to find out any information, to read reviews, to see all of the diagnoses and dysfunctions that we treat, go to www.zionpt.com. and you'll be able to find everything that you want on that website. So we'll take some time to do Q&A, but I want to thank you all for attending this webinar. I really hope you learned a little bit about the pelvic floor and what we as pelvic health PTs can provide to the postpartum population. If you have any questions, please, please, please reach out, whether you're pregnant, whether you're about to give birth, whether you're in the postpartum period. The postpartum period is anywhere from like the day you give birth all the way until like decades after. So if you're still experiencing things, 20, 30 years later, 5 years later, 2 years later, there's so much that we can do for everybody who has gone through childbirth. Please don't feel like you are being silly by reaching out, because we really can help and make a difference. Again, we treat all pelvic floor dysfunction, men after prostate cancer when they've had a prostatectomy, women in the postmenopausal period who are experiencing changes with urinary function, sexual function, all of it. So we are happy to take your questions and see you in the office. And thanks so much for attending.